clear investigated the use of lenvatinib plus pembrolizumab and compared that to sunitinib in untreated patients with metastatic clear cell carcinoma. So it's first-line setting, and len-pem was superior to sunitinib in regard to efficacy and overall survival. So what we were interested into was really understanding in a better way, what is the impact of the tumor load at the baseline setting. So when you have a certain amount of tumor to begin with, to start off the therapy, does it impact the outcome? And that was kind of the exercise that we have been into, and we looked into quartiles, so we broke it up into different quartiles and see how that related to objective response rate, to progression-free survival and overall survival. So I think the overall len-pem was superior to sunitinib, and it was irrespective of the tumor load. But what we did see is that the objective response remained the same. We have seen that PFS was similar, but in OS there was a trend, I would say. So patients with a heavy tumor load seem to have a poorer outcome, but overall the benefit was still there. So I think that is what we have seen, that len-pem maintains the activity, but in certain aspects it might have influence on the prognosis of patients in that treatment setting. We stopped having additional follow-up, so it's the final analysis that we looked into, so the data is mature and robust in regard to overall survival, and I think it's it's an interesting aspect that we can see in this subgroup of analysis. Yeah, I think it's not as simple at the end. We like it to be just two different ways. It's yes or no, or black and white. But at the end, I think it's more complex than that. So it's not a single factor that's really driving the decision-making process. So I think the first-line setting has become increasingly effective in the past years. We have seen an increase in overall survival and oncological outcomes for patients that have been treated with those novel combinations. I think they all have benefits and risks that you take when it comes to to a certain type of therapy, and that makes it so difficult because we don't have a formal head-to-head comparison, and that's why we rely on additional data to try to understand or figure out what is bringing in the impact really, and that's why we did the meta-analysis. And what we have seen is that len-pem prevailed in its benefit, so overall survival benefit was maintained. But what we do see, or another way to take it is, I think combinations improve overall survival. That's what we see. And there are certain strengths and weaknesses that come along with each of those combinations. It could be toxicity, it could be, if you have a TKI-IO combination, you broaden up in terms of response, so you have a better response rate, better control of the disease in the initial phase of the treatment. I think that's the large benefit that comes along with the type of combination. Whereas with IO, just narrow down, but you aim for long-term effects, basically. So there is, benefit with each of those combinations, and it's a luxury in the clinic because you have the choice, and so you can see for a single patient what would be the best match in terms of the combo that you would go for. So there will be a European trial that will do the head-to-head comparison, but it will take years until we finish that specific trial. It's about to start right now, actually. So we will have some answers in, let's say, 5-6 years' time, but until then, I think we rely on indirect comparisons. Network and meta-analysis is one way, or you could do other computational analysis to do an indirect comparison. But I think at the end, it's just an approximation towards the real effect that can be considered. But I think as it is right now, I think it's okay. I think it provides evidence to use these kind of combinations in the first line setting.